I'm going to be talking about using SPECT-CT in imaging the extremities. I'm going to cover the acquisition parameters we use and go through some reconstruction techniques. I'm going to be going through some of the relevant anatomy of the foot and ankle, and I'm also going to cover pathology of the foot and ankle, and I'm going to show you some examples of SPECT-CT of the wrist. This is our standard SPECT-CT acquisition for the foot and ankle or the wrist. Essentially, the SPECT acquisition is fairly standard with 8 seconds per frame. The CT acquisition uses a fixed MAS without the dose modulation. We use thinner slice as possible and an overlapping pitch. We also perform a small field of view reconstruction, which gives us better image quality, and I'll go on to explain why that's useful later. When you're imaging the hands and feet, it's really important to take some time to consider positioning of the patient. It's really important that you try and image both sides at the same time, so you have the opportunity of comparing the left and right hands or feet. It's also really important that you try and immobilize the extremities, so either using a device such as the ones shown here, that will keep the feet together and also immobilized, but also you need to consider whether it's worth trying to position the feet so that they're anatomically positioned. The difficulty with some of these devices is that the toes may be pointing forwards and together, and when you're reconstructing the images and interpreting the images, it's very difficult to reorientate the anatomy when the feet are not imaged in an anatomical position. I mentioned earlier that we use a small field of view when reconstructing the images. This slide shows why this is important. On the left, you have a scan that's been performed with a large field of view and reconstructed with a large field of view. So the display field of view includes everything that's been scanned. Now, when we're scanning patients with SPECT-CT, we tend to use a large field of view because we need to make sure we include everything up to the skin so that we can perform accurate attenuation correction on our SPECT images. However, when we're displaying the images and we're doing fused images, we don't necessarily need to see so much of the field of view. So we reconstruct our images with a smaller field of view. So we'll have a large field of view that's reconstructed for the attenuation correction, and a smaller field of view that's just over the hand or the wrist or the ankle in question to give much more detail. So you can see how the image on the right has a small field of view and is a much higher resolution than the one on the left. And these are exactly the same acquisition. They've just been reconstructed with different fields of view. When we reconstruct our foot and ankle and our wrist scans, we have a different protocol for how we reconstruct those. So instead of just using a straightforward axial, coronal and sagittal, we also reorientate the reconstruction planes to the joints that we're imaging. So for instance, in the ankle, we will do an axial, and then from the axial, we will work out a coronal oblique and a sagittal oblique. This is so that coronal view and that sagittal view is in line with the ankle joint. I'm going to run through some anatomy of the ankle so that you're familiar with what you're looking at when you're looking at the CT. So on the left is a CT image, and in this case it's an axial image through the ankle just above the level of the tibio-talar joint. On the right is an MRI image, and I've only shown you that there so that you can compare the soft tissue anatomy and you can see some of the landmarks. So we can see here you've got the tibia and the fibula, and in between the two is the tibio-fibular syndesmosis. This is a very important articulation that gives stability for the ankle joint. Soft tissue things to look at in the posterior ankle are the flexor tendons, so you can see tibialis posterior, flexor digitorum longus and flexor hallucis longus, and on the lateral side you can see peroneus longus and brevis. If we scroll a little bit further south, we will come to the level of the tibio-talar joint, and now you can see the talus in the middle, and you can see the medial malleolus and the lateral malleolus. And the joint lines that are highlighted by the blue arrowheads are the tibio-talar joint itself, and you can see how those joints should be nice and even and should be a uniform distance around the joint. If we switch over to the coronal view at the same level, we can see that the tibio-talar joint is highlighted there by the yellow dashed line. On the medial side, on the soft tissue views, we can make out the deltoid ligaments with looks like a fan shape and has medial deep and superficial fibers, and you can see the striations there of the ligaments. If we go a little bit further south, we can see at the level of the concavity of the fibula, and this is on an axial view again, we can just about make out anteriorly the anterior talofibular ligament and posteriorly the posterior talofibular ligament. And you can just about make out those on CT, although they're much better seen on MRI. If we look at the sagittal view, I find this very useful for looking at the subtalar joints. Now the subtalar joints are the articulation between the talus and the calcaneus. There are three facets. There's a large posterior facet, there's a middle facet, and then there's also a small anterior facet, which is not always present. When we're on the sagittal view, it's also worth looking at the soft tissues, and you can see the Achilles tendon, and you can assess for thickening of the Achilles tendon on the CT component. You can also see where the plantar fascia inserts, and if there's evidence of calcaneal spurs, you will see them at the site of the origin of the plantar fascia. We've looked at the hindfoot, now we're looking at the midfoot. Now the midfoot is a complex set of joints that forms arches across the foot and supports the weight of your body and distributes it from the hindfoot into the forefoot. You can see here on the sagittal view, you can see the talonavicular joint on the left, and more laterally on the right here you can see the calcaneocuboid joint. I find it's quite useful to perform another reconstruction when you're looking at the midfoot joints. So if you reconstruct your images with the long axis along the plane of the first metatarsal, that opens up the midfoot joints. So this image here on the left is an oblique image through the midfoot, and you can see how the joints form a nice curved S-shaped articulation. And this allows you to look for any subluxations or dislocations, and also helpfully allows you to count the cuneiforms and make sure actually all the bones are there that you expect to be there. So you can see the proximally in the midfoot, you've got the talonavicular and the calcaneocuboid joints. You've then got the navicular cuneiform joints, and then you've got the tarsometatarsal joints or Chopart joints. Finally, if you look on the sagittal image here on the right, you'll see you can assess the first metatarsophalangeal joint and also the sesamoids in the first toe. So let's look at some of the pathology that we might see on SPECT-CT of the foot and ankle. One of the most common indications for a SPECT-CT of the foot and ankle is to assess for instability. Usually this is the result of a previous trauma, may have been a significant sprain with ligamentous injury, could have been a fracture like this. And in this case, this patient has had a syndesmotic injury and they've had an attempted internal fixation with plate and screws. As you can see here on the image, the screws have fractured, and this has led to chronic instability of the distal tibiofibular syndesmosis. And so this ankle is unstable as a result of this chronic movement. And we can see there's intense increased uptake at that site of articulation where it should be fused. So when I'm looking for instability, I'm looking on the axial images. I'm looking above the level of the tibio-talar joint. I'm looking at that distal tibio-fibular syndesmosis. And it should be nice and smooth, and the distance between the tibia and the fibula should be even along its length. If it isn't, you can get chronic instability, and you can start to see focal abnormal uptake in the syndesmosis itself, but also in the tibio-talar joint. So this is an example of a patient who's had previous internal fixation of an ankle fracture, but unfortunately the screw has eroded through into the joint itself, and we are now got significant post-traumatic osteoarthritis. So osteoarthritis in the ankle is rare. It's not common as a primary pathology as in the hips or the knees. However, following injury, it is a relatively common complication in the long term. This is a different pathology which can often be confused with osteoarthritis, but in this case, it is an osteochondral defect. You can see the subtle lucency on the CT along the medial aspect of the talar dome, and this is associated with intense increased uptake. Of course, the cartilaginous component of this can't be seen on the CT, but could be better seen on MRI. But the focal uptake and lucency on the CT suggest that there is an osteochondral defect and can point towards that as a diagnosis. Notice how the uptake is confined to the talar dome. There isn't any corresponding uptake in the tibia to suggest this is osteoarthritis. Again, contrast this with a case of infection of the ankle. Ankle infections are rare. This is actually a case of TB of the ankle joint, and you can see how there's irregular lucency across both sides of the joint, which is concerning for infection. There's intense increased uptake, and on the axial image there you can see there's a small sequestrum or piece of dead bone sitting within that cavity. I'm going to talk a little bit more about impingement syndromes. This is a case of posterior impingement, and it's due to an accessory ostrigonum. So in this case, there's an accessory ossicle sitting adjacent to the posterior aspect of the talus. This is another cause of posterior ankle impingement, but in this case, instead of there being a separate accessory ossicle, there is a STIEDA process, which is an outgrowth of the bone. So similar to an accessory ossicle, but it's fused to the talus itself. Because of that outgrowth and that protrusion, it results in impingement on the ankle during flexion and can be seen as focal increased uptake on the SPECT-CT. This is a case of medial ankle impingement, and this is an advanced case in a patient who has had previous ankle injury, probably quite a significant previous ankle sprain with ligamentous injuries involving the deltoid ligaments, and as a result they've now got post-traumatic osteoarthritis with osteophytes arising from the medial malleolus, and you can see how that medial articulation between the medial malleolus and talus is irregular, and that is leading to medial ankle impingement and bony impingement with intense increased uptake. We can also see cases of anterior impingement. So these are sometimes associated with athletes who have chronic repetitive stress injuries to the ankle. You can see in this case there's an overgrowth on the anterior aspect of the tibia and can impinge on the talus, causing anterior impingement. This is a case of quite advanced lateral ankle and hindfoot impingement. These cases can be often associated with a valgus hindfoot deformity, sometimes related to flat feet. And in this case, you can see how there's been chronic instability of the ankle and whole of the hindfoot, resulting in subluxation and now the lateral malleolus, the fibula, is actually impinging on the talus and also the calcaneus. And you can see how the SPECT-CT highlights this change in biomechanical force and stress quite nicely. So I'm going to talk a little bit more about hindfoot malalignment and how SPECT-CT can be useful in assessing for hindfoot malalignment. So in this case here, we can see there's focal increased uptake in the lateral aspect of the subtalar joints, and this is resulting in arthritic changes. So we can see there's also some subchondral cystic changes. And this is because there is a valgus angulation. And there's good evidence to show that when we're seeing uptake in the hindfoot on the lateral aspect, that this correlates with valgus angulation of the hindfoot. So you can imagine as the patient is walking and weight bearing, there is chronic movement and stress on the lateral side. And it doesn't matter that we haven't imaged the patient in a weight bearing position. The fact that we can see the uptake on the lateral side shows that there is chronic stress on that side, which indicates that the patient likely has valgus angulation. And again, similarly, we can see increased uptake around the sinus tarsi. Now, we are seeing some degenerative changes there along the calcaneus in a site that isn't a joint. There isn't a joint there to be causing arthritic changes. So what we're seeing is sinus tarsi compression. So again, there may be an associated lateral hindfoot malalignment, but what we're seeing is chronic repetitive stress on the lateral side of the hindfoot, resulting in compression of the sinus tarsi. Something else that's worth considering, particularly when you're scanning younger patients, is tarsal coalition. So tarsal coalition is when there is a congenital fusion of the joints in the foot or ankle. And in this case here, there's a fusion between the talus and the calcaneus. And you can see how, although the coalition is visible on the MRI scan, there is very little edema associated with that. So there is a fibrous coalition there, but actually there's quite intense uptake, suggesting that there is a pseudoarthrosis and chronic repetitive stress and motion at that level. So it goes to show how the findings on MRI can be quite subtle and sometimes missed, and SPECT-CT highlights those findings quite easily. When we're on the sagittal view, I will also just check out a few structures. So again, just look at the plantar fascia. Here on the left, you can see there's focal intense uptake within the base of the calcaneus. So this is related to plantar fasciitis. And again, in the calcaneus, here more superiorly, there's focal uptake at the Achilles tendon insertion site. So this is related to Achilles tendinopathy. And you can see there's some associated thickening of the Achilles tendon. This is a case of avascular necrosis of the navicular. And you can see how the bone is sclerotic and it becomes flattened. And the example on the right shows how a more advanced case where there is flattening of the navicular and subluxation as a result of advanced avascular necrosis. In the forefoot, this is a common finding that we can see on SPECT-CT. You can see on the left image a plain film showing very subtle periosteal reaction in the fourth metatarsal. This is much clearer on the SPECT-CT where there is focal intense increased uptake and the periosteal reaction is seen on the CT. So this is a stress fracture, sometimes called a March fracture because it's due to repetitive weight bearing. FRIEBERG'S disease is a name for avascular necrosis of the metatarsal head. It typically involves the second or third metatarsal heads, can lead to flattening of the metatarsal head, and you will sometimes see in advanced cases secondary arthritis with uptake on both sides of the joint and advanced subarticular cysts on the CT component. SPECT-CT is very useful in assessing post-operative complications, particularly fracture union. This is an example here on the left where a patient had an ununited fracture of the base of the fifth metatarsal, quite clearly seen on the plain film, but the surgeons wanted to do a SPECT-CT before they went ahead and fused that joint. And when we did the SPECT-CT, we could see that not only was there a ununited base of the fifth metatarsal fracture, but actually there was degenerative change in the fifth tarsometatarsal joint. And this changed the surgical management. So when they went to go ahead and operate on this patient, they also performed a fusion of the tarsometatarsal joint as well as fusing the ununited fracture. If they hadn't done the SPECT-CT, they may well have treated the fracture and missed the degenerative change, which may also have been contributing to their pain. This slide also shows how SPECT-CT is very useful in assessing for non-union. We can see the plain films on the left here are next to useless. We can see that the surgeon has performed an attempted fusion of the ankle joint and has inserted bone graft material in and around the joint to try and help everything to fuse, but it's difficult to assess whether the fusion's been successful or not. When we look at the SPECT-CT, we can scroll through various images and we can see here on the right, for instance, that there's still a lucency through that articulation. So this is an ununited joint. The fact that we've got increased uptake around the joint also suggests that there is still viable bone, and this patient went on to have a successful reoperation. Ankle replacements are an uncommon procedure in the UK. However, we do have some success with performing SPECT-CT in these patients. Just like in other joints, SPECT-CT is very useful because it doesn't suffer from the artifact that MRI does, and the combination of the SPECT and the CT gives us a useful insight into the pathology. One of the most common complications we see with ankle replacements isn't loosening or infection, but actually impingement syndrome. So in this case, what's happened is you've got progressive osteoarthritis and you've got medial ankle impingement, where you've got the overgrowth of the medial malleolus contacting and pressing on the talus. And you can see that the uptake is there just on the medial aspect of the joint replacement itself. And this is because this patient has obviously had long-standing arthritis in that joint, but obviously they will have weak ligaments as well, and so they are susceptible to chronic instability regardless of the joint that's been replaced. I don't have many examples of SPECT-CT of the hand and wrist, and the reason for that is fairly clear. It's just not that useful over and above, say, MRI for a lot of indications. However, I have got examples here of where it is better than MRI and can be useful. So the first indication is thumb-based arthritis. The reason why SPECT-CT is very useful is because the surgical management depends on whether the STT joint is involved or not. So that's the articulation between the scaphoid, the trapezium and the trapezoid joints, bones. So there is an Eaton classification that surgeons may well use in order to determine whether that joint is involved or not, and that is based on plain films and also clinical examination. The SPECT-CT is helpful in differentiating a stage 3 from a stage 4 joint, and this is because it allows us to evaluate whether the STT joint is involved, and this has different surgical management. So, we sometimes do MRI scans for this indication. I think SPECT-CT is better because it more accurately localizes sites of arthritis in the wrist. This is another indication that I think SPECT-CT is quite useful for. This is ulnar abutment syndrome, and essentially this is where the ulna is excessively long and impinges on the carpus, on the ulnar aspect of the carpus. It can present with chronic or subarticular ulnar pain. It's often associated with a positive ulnar variance. In this example here, this is because the patient has had a previous fracture of the distal radius with dorsal angulation. The fracture has united, however, it's resulted in a longer ulnar and impingement on the underside of the carpus with increased uptake. There's also findings of ununited fracture of the ulnar styloid. Ulnar abutment syndrome can also be associated with triangular fibrocartilage tears and also wear on the lunate, which will show up as increased uptake on the lunate. So I'm going to end with a few tips. I'm just going to reiterate, it's very important that you use isovolumetric reconstructions when you're performing the SPECT-CT. So try and use as thin a slice as possible with overlapping pitch if possible. I would really consider reconstructing your CT scans according to the joint in question. So if your clinical query is regarding the ankle joint, then reconstruct your images according to the tibia-talar joint. If you're looking at the forefoot or midfoot, reconstruct your images according to those joints separately. You should use a small field of view for display. This will really help improve the resolution of your images and also produce something that is a little bit more like what surgeons are used to from diagnostic CT. I would also encourage you to use 3D volume rendering. I find it's very useful when you're assessing the foot and ankle, particularly after patients have had surgery or patients have had a previous injury. You might notice that there's change in biomechanics and changes in stress, which you won't really notice if you're scrolling through a stack of images. Thank you very much for your attention. If you have any questions or you want to discuss foot and ankle SPECT-CT or wrist SPECT-CT further, I'm happy to take any questions. Feel free to email me on my email address shown here.